David, good morning. It gives me great pleasure to be able to introduce you as the Reuben College Oxford Computer Consultants Fellow of Machine Learning and Artificial Intelligence. David, I'd like to talk to you this morning about the application of artificial intelligence in health and indeed in social care. At Oxford Computer Consultants, we have over 80 local authorities and health trusts that we provide software for. And it's very interesting to think about how the applications of AI in those areas work, and particularly looking at the social care area. So I'd like to sort of talk to you a bit about that and maybe get some of your thoughts on that. And health and social care are often sort of banded together as one term, and AI is already having a major impact in healthcare. Could you talk about some of the major applications of AI in healthcare that you've been involved in?
Yeah, certainly. So wherever there's data, you can build an AI system, and interacting with the healthcare system creates a lot of data. You go to your GP, your GP starts to record data in one particular data system. If you're referred to hospitals, you're of course getting richer data during your hospital stay. We might be wearing wearables ourselves at home. We might be discharged from hospital with a particular device or so. All of that leads to ever increasing amounts of data throughout every individual's life. And if we look at some of the data sets that we have with our clinical partners at Oxford University Hospitals, some of those go back to the 1980s. I mean, they're really long histories of data. So you can do quite a lot of good things for medical science if you have lots of rich histories of patient data. And you'll be able to, for example, make predictions about disease state, the onset of disease, the change of disease, the response of individuals to treatments, and all those good things. So there's plenty of exciting stuff to do. Oxford University itself, under the leadership of Professor Lionel Tarasenko, has had a lot of those firsts, a lot of those important case studies that have shown for the first time how AI can be deployed in real healthcare systems. And my interest is really on the AI side. How does AI have to respond? How do we have to change and develop AI to make it suitable for healthcare systems?
Mm-hmm. And what do you think are the next steps for your work in this area? What are the exciting developments we're going to hear about from your work?
Well, in my field, the Holy Grail is really linking up all of the different bits of the data and being able to use all of those data for big predictive systems. So as I'm sure you know, in the UK and in many countries' healthcare systems, primary care, so that means your GP, the doctor you go to see maybe once a year or so, depending on your condition, is really separate and distinct from rich hospital data, and almost never the twain shall meet. But of course, the GP has been seeing you for decades. There's a lot of information there. And when you turn up at the hospital, it's not the case that nothing is known about you. There's a lot of histories there. It's just that they happen to be in a different computer system. Mm. So you can imagine across all the disease areas, how joining these different lagoons of data up, these different parts of the patient history, can really lead to exciting outcomes. So I do a lot of work with companies that make medicines and things like that about how to identify disease earlier and quicker, because the earlier you spot a disease, the easier it is to treat, the better the patient outcomes, the longer patients live. So there's a huge amount to do.
So I just want to drill down a little bit into this NHS data, because there's been a lot of talk in the press about the Americans want to buy our health service. And actually they don't. What they're interested in is our data, isn't it? That's really, they're not interested in buying our hospitals and our surgeries and our pharmacies. What they're interested in is our data, because we have this national data set. So that's what, do you agree? That's what Google are here, and IBM with Watson. Is that the bit they're trying to tap into?
Well, I would say, the NHS, because it's a single payer system, it is obviously a repository, a big repository of data. And data is, people say data is the new oil. Mm. I don't think it's quite fair to say that the NHS is sort of one data set, because it is. Yeah. Every hospital trust itself has got its own governance, and every network of general practitioners has got its own governance. So it's federated in that sense, but there is a hell of a lot of data there, and it is all under the umbrella of the NHS, and it is extremely valuable. I can't really comment on the motivation of overseas companies, but it is recognised that it's a massive resource, both for medical research, the kind of stuff I do in in building new things to help help manage disease better, but also it's just intrinsically valuable itself. And how one ensures that the value of this new oil is benefits the UK and the NHS is critical. That's part of. I was born in the NHS, growing up in the NHS. It's like every other British person, the joke is that the NHS is the closest the British have to a national religion, for a good reason.
Yeah,
right?
Absolutely. No politician dares touch it for that reason. And of course, this is why it's so important that groups like yours are involved with all these spin-out companies, OCC Health and Sensine, because this is the UK's opportunity to make sure that we grab this new oil, that we don't just allow organisations from other nations to benefit, particularly because we have that unique data set. So I think it's very important. I just want to focus in a little bit more about what I think is, wondering what your thoughts about what's so important about this data. And I think it's because it has the outcomes in it. In other words, you have all these parameters, your blood pressure, your scans, everything is there. But actually what's really exciting is at years 5, 10, 15, did you develop this condition, that condition, are you alive still, and so on, this outcomes data. And when we come on to talk about social care data, I think that's where the problem comes in. So is that your understanding, that it's the fact that we've got the outcomes and not just the input parameters that make this so good for machine learning scenarios?
Absolutely, that's the fact that it's been partly labelled by clinicians is hugely important. Yeah, you can't just hope to acquire, exabytes of unlabeled data and hope there is some value in that, but the value, as you rightly point out, is knowing what that happens in disease progression. I can only imagine how that plays out in social care, because obviously there's a paucity of data collection in social care. My father went into a care home a couple of years ago, and I'm fairly familiar with the way that care home residents are monitored and their interaction with the healthcare system. They might see a GP every now and again, and it got to the stage with my father where the GP comes to see him. But yeah, data collection there is pretty limited. So the type of machine learning that you do and the kind of applications you build, again, have to be fitted to the constraints of what's available.
And I think also perhaps the difficulty is how you define outcomes. I'm interested in the medical domain, actually, what are the outcomes you work with, and how might those be mapped to other domains?
So there's hard outcomes. So does the patient live for 10, 15, 20 years after having this medicine and this treatment pathway? There's soft outcomes as well, which I sense might be as relevant for care home and patients and social care as others, in the sense that for a lot of people, it's about measuring the quality of life, and actually medical practice and interventions are based on quality of life-adjusted years. So is a medicine going to buy you QALYs? Is it going to buy you good quality living for extended periods per unit cost? And so that's often how the health economics of these things are done, of course. So my sense is that when you're dealing with patients who are not in care homes, it's much more feasible I imagine, to collect this quality of life kind of stuff. So there's standardized questionnaires where you can ask people, great systems like True Colours, developed by colleagues at Oxford, where you can, through an app, record your quality of life and how you're feeling day by day. Different game, I suspect, for social care. Obviously in social care, it's a spectrum of people, spectrum of residents there, in the sense that you've got people who are very tech savvy and quite happy to report outcomes, I imagine, but all the way up to people who are, like my father, not able to do that. So that's a definite constraint.
And one of the areas I've been looking at a little bit recently is the emerging area of synthetic data. I've been wondering whether that can help. You talked about small data in some of your work.
Yeah.
And I wonder what you think about the use of synthetic data as a way of enhancing the models and doing machine learning.
That's a really nice question. So it used to be that the use of synthetic data was absolutely verboten, completely forbidden. What extra value can one possibly have just by making up the data? That has really changed. And the evidence has been demonstrated in most fields that you can augment your data set, particularly if you've got a really complex model. You can augment your data set by generating things that look like the training examples that you've got. And we do that a lot. So to use the jargon, generative adversarial networks, GANs, are particular types of model, as one of many, that learn from data, but what they're doing is not predicting anything, they're just using it to generate new data types. And you see synthetically generated faces, for example. They really pass the Turing test now.
Yeah.
You can generate artificial faces that look and feel human, but they're no recognizable person. And I like to throw these up in my lectures occasionally. You can do that with all sorts of healthcare data as well. It's really valuable to do that in healthcare because medical science is restricted, and rightly so, by the availability of data. So we can't share, we've got vast quantities of data, ethically approved, governance approved with our clinical colleagues, but we can't share that with other medical researchers because we don't have the ethics to do that, understandably, because the patient's only given us consent to use it. But what we can do is share models with other people that generate data that look a bit like a patient's, where it's demonstrable that the data it's generating are from no particular patient that they've seen before.
So you've got the anonymization.
And the privacy guarantee has been baked into the data generator. And there, because the models are really complex, they like to have more data in many settings. So having a data generator to chug out gazillions of different examples of things that look a bit like patient data really do help in setting a machine up and improving performance.
Yes, I think it's a fascinating area, and it may help to address some of the more difficult to address fields where the data sets are poor, or where the privacy is so much of an issue that you have to actually generate new data sets from them. There have been some interesting applications of AI in social care. One that sort of made the news recently is things like that 4-foot-tall robot called Pepper. Right. So the early images of AI were these sort of rather scary-looking robots that sort of went round and then took over the world. But actually, AI is appearing as a small seal which you can stroke and which interacts with you in a friendly setting. And in fact, evidence shows residents reacting extremely well to these. To what extent do you see these sort of technologies, this sort of humanization of the technology, being an important step when we take this into sort of health and social care areas?
Well, I think it's really important. It generally comes under the umbrella of affective computing, affective computing, sort of understanding and responding to human emotions and so on. So computers that don't just recognize what it is that you're asking, but they recognize your mood and potentially why you're asking. So you can imagine that for care home residents, I'm sure care homes, I know for a fact from the case of my father that care home staff do a great amount to look after their residents, but residents necessarily are on their own for some time, and having some extra companionship is fantastic. For the current older generation, they're not really tech natives, so to speak, and maybe they find that companionship in different ways. When me and my children grow up, I'm pretty sure we'll be thrilled to have a digitally enabled version of Chubbs, the pet seal that my children have at home. I think there's huge amounts to do there. Perhaps it will prolong. Perhaps it will avoid the deterioration of mental decay, stimulating someone who might otherwise be alone for long periods of time, engaging them. In a way that's not trivial, in a way that helps them to understand. Maybe they play games with them, etc.
One of the challenges we face as technologists is we have to be aware of the digital divide. It's a truism ever, though very interestingly during COVID, actually it's helped to bring a whole generation of people into technologies who it might have been difficult otherwise. But I wonder to what extent it's important that AI does a lot of work on the human-computer interface to make sure that we don't exacerbate that digital divide, and that we really focus our research on things like chatbot technologies and natural language processing and dialect elements of that, because at the moment natural language processing works fine for the somebody who speaks sort of the Queen's English but doesn't do so well otherwise. Is that an area of research you've been looking at, and do you think there's some good progress to be made there?
Personally, the kind of stuff I do is I develop systems for experts. So whether they be clinical experts or jet engine experts, whatever it might be. They're just looking for tools to help them understand massive data sets. So personally, that's what I do. The AI community itself is understandably focusing really a lot of its efforts on explanatory AI that's able to be used and fits into the hands and the work and lifestyle of people. Obviously, the big multinationals have got a big vested interest in doing that. And you will know as well as I that things like chatbots have come on leaps and bounds. It used to be the case, if you go to a web page and you get a chatbot, that you would know that it was valueless to do that. You would seek out the human who's going to give you the real information. These days, actually, because these chatbots are, there's a lot of information you can get there from a chatbot these days, which is potentially even better than the untrained call center person that you would otherwise seek to call. So, because of the improvement in technology, there's an understanding that actually that this has a part to play in my life.
Yeah. And in your work, do you work with sociologists and sort of psychiatrists as well? Because there was a fascinating application with a chatbot where we developed a chatbot technology. And what the sociologists told us is, if you get the chatbot to say, we promise you won't lose your place in the queue, but would you like to try the chatbot? The bit of saying, we promise you won't lose your place in the queue, you're on the phone or whatever, made all the difference.
Indeed.
And then we got, to what extent have you had any experience of involving that element of?
Yeah, the human, I suppose in my area we call it human factors. So the human factors bit is really big now. And if you standard scientific process is that you write a proposal to say how you would like to do this big program of science, and then you have to say all the impacts you think it's going to have and show how you're going to develop those impacts. A key part is that I will be working with human factors teams to ensure that the stuff I develop is not engineers in a basement designing stuff for other engineers. Right? It's got to get into the hands of a nurse or a car driver or whatever it might be. So you have to bake that in from the start.
Okay. David, thank you very much. It's been a fascinating set of answers and been a pleasure to talk to you, and look forward to maybe next year talking about how the work's progressed and the new areas you've been involved in. Thank you.
Thank you.